Welcome to today's edition of Patcast. Today is July 16th, 2025, and it's a Wednesday, not the regular Tuesday that we usually have our sessions. I'm Rifat Mannan in Los Angeles, California. So I am joined today by Dr. Dirk Elston, and who needs no introduction to the world of dermatology and dermatopathology, who know them very well. And actually, this is his second lecture on our platform. And today he is going to give a talk on infectious dermatopathology, the second part of it. And just to reiterate about Dr. Elston, and he has been a prolific and accomplished dermatologist and dermatopathologist, and his textbook on dermatopathology has inspired a lot of pathologists and dermatologists across the world, and it is already in its fourth edition. I am sure many of you might have already read it. And Dr. Elston serves currently as professor and chair in the Department of Dermatology and Dermatologic Surgery at Medical University of South Carolina at Charleston, USA. And we are very lucky to have Dr. Elston with us today. Over to you, Dr. Elston. And we are also today joined by Dr. Skapsky. Dr. Hada Skapsky has been instrumental in putting this series on dermatopathology lectures together, and we really thank Dr. Skapsky for that. And this is actually the 9th lecture in the series. Over to you, Dr. Elston. Thank you so much.
Well, thank you so much for the invitation. Infections are, an area near and dear to my heart, and so we'll be going into the second part of the discussion of infections. And we're going to start with a picture of a North American fish, a spotted rose snapper. So why would I show you a picture of a fish? Because the tongue of the fish has eyes. Because it is not a tongue, it is a creature that crawls into the fish's mouth, attaches to the fish's tongue, slowly consumes the fish's tongue. But it's not actually classified as a parasite. It's classified as a commensal because it takes the place of a fully functional tongue, except that it takes the first bite of everything that the fish eats. And just in case you thought you were safe, there is human tongueworm. So you are sleeping and your mouth is open and they crawl into your mouth and attach to your tongue, and you present with inflammation, cough, coryza, lacrimation, facial edema, and ultimately asphyxiation. Fortunately, this is only seen in parts of Asia, Africa, and a small area of Southern California around Los Angeles. That last part's not true. That was for your benefit. Okay, I love case-based learning, so we're going to start with a woman who found an 18-year-old bottle of eye drops in her medicine cabinet. And you know what happened next? She decided to use them. And, when she came out of her coma and was talking to her daughter, who had in her hand this bottle with the yellowed, peeling label, and saying, "Mom, what were you thinking?" So when we met her, she was comatose. Her eye is swollen. The globe itself is completely opaque, and she ultimately lost the globe. But the important part, of course, is the dermatopathology aspect, where you see a dead vessel and there is not an inflammatory cell anywhere in sight around that vessel. Instead, what you have is a blue haze of organisms. And that blue haze is characteristic for Pseudomonas sepsis. So not surprisingly, she grew the same organism from the bottle, from the globe of her eye, which had to be removed, and from her blood. So Pseudomonas endophthalmitis in this case, she did ultimately survive sepsis, but the key, of course, is derm path, because by the time it grows in culture, the patient is often dead. So, early diagnosis by biopsy is key. So the next patient is a 34-year-old female with sent in for, quote, unresponsive tinea pedis. And any dermatologist worth his or her salt knows this is not tinea pedis. These are ham to copper colored lesions with a peripheral adherent scale. That is syphilis. The problem is that serology was negative, and a T-Pal test had been done on the tissue and was negative. So this is the histology. And one of the things you see, first off, busy dermis, no lumen to the vessel, a mixed pattern of spongiotic and interface dermatitis. Anytime you have mixed patterns of dermatitis, interface plus granulomatous, spongiotic plus interface, think of drug viral syphilis, drug viral syphilis. If you remember that for mixed patterns, you should think of drug viral syphilis, you will save a lot of human misery. So in this case, you have the elongation of the rete, whereas an interface process would usually give you attenuation of the rete ridges, right? Here you see elongation of the rete. One of my fellows said long, slender, sexy rete ridges. If that helps you remember syphilis, the sexy rete ridges, that can be one way to remember it. Neutrophils in the horn, psoriasis, tinea, impetigo, candida, sebderm syphilis, P-ticks is a mnemonic we often use for that. There are often neutrophils within the epithelium itself. The lumen of the vessel is usually inapparent because of endothelial swelling, and there is commonly not a plasma cell in sight. In fact, when we've looked at other interface processes that tend to be a lymph in every vacuole, which is the pattern syphilis tends to have, and you look at other conditions that can cause that, like mycosis fungoides and especially pityriasis lichenoides, which would have a neutrophilic scale crust and mimic syphilis, pityriasis lichenoides is more likely to have plasma cells than syphilis is. Syphilis has plasma cells in only about 2/3, pityriasis lichenoides in 70%. Syphilis also only stains with immunostains 70% of the time. So if you think it's acceptable to miss 30% of all cases of syphilis, you can depend on the T-Pal IHC. If you don't think it's acceptable to miss 30% of all cases of syphilis, you still have to do silver stains, serology, clinical correlation. This patient had rip-roaring syphilis and a strong prozone reaction when treated. So the other thing that you see is that the interface process almost fogs out the rete ridges. So the expression London on a foggy day, where the buildings disappear in the fog of the infiltrate, has been used to describe it. Plasma cells can be present, but remember, folks, it's only 2/3, right? So 1/3 of all syphilis cases have not a single plasma cell in sight. And when you look at the differential of things with interface and scale crust, like pityriasis lichenoides, it is not syphilis that is most likely to have the plasma cells. So again, here you see, sort of a classic syphilis. Long, slender, icicle-like, or if you prefer, long, slender, sexy, rete ridges, busy dermis. There are vessels, but there's no apparent lumen to the vessel. Those are all big clues. That's, a vessel. When I entered derm path, I was looking for puffed up endothelial cells because the description is always endothelial swelling. Think of it as absence of lumen. If you think of it as absence of lumen, it's far more easy to identify. In this case, there was a proson phenomenon. The RPR card test turned positive with a 1:64 dilution. We've had cases where they have to dilute far out in order to get a positive test. This is not the patient's immunohistochemistry. The patient was stone cold negative, but was positive on a silver stain ultimately. So what are the criteria that discriminate? And ask yourself, how much syphilis are you missing? These days, with syphilis on the rise, if you are not seeing syphilis in your practice, it is probably seeing you in your practice, right? So wide spectrum from the initial chancre, chancres that are often inapparent, especially if they're internal in a female. What we mentioned, the ham or copper colored macules acrally with a peripheral scale, gyrate hyperkeratotic lesions, especially in patients with darker skin types. Again, you've got a little bit of a gyrate annular lesion on the scrotum of that patient, mucus patches. This patient also has molluscoid lesions that were disseminated cryptococcosis because the patient had undiagnosed HIV infection. Mucus patches in the mouth are a particular problem because many patients the word on the street is that oral sex has a low risk of HIV transmission, so many people are not using protection for oral sex with multiple partners. Mucus patches in the oral mucosa are highly infectious for syphilis. Here again, you have mucus patches and a characteristic gyrate appearance. And then mucus patches in the anogenital area get a special name. We call them condyloma lata, lata for broad, to distinguish them from condyloma acuminata, which are kind of lumpy, bumpy, pointed. And then, of course, the eruption. The eruption is transient. If you misdiagnose it, if you treat it wrong, if you treat it with corticosteroid, it goes away because it's a transient eruption. And then, of course, the long-term consequences for the patient are dire. When we have studied syphilis, we found that the majority of cases often were not suspected clinically when a biopsy goes to the lab. We see it in old men where the clinician isn't thinking syphilis because he's an old man. They are often widowed and lonely and looking for companionship. Old women in nursing homes, we have seen it where they are victims of sexual abuse. And again, if you don't even consider the diagnosis, the consequences for the patient can be bad. So the classic presentation, plasma cells in only 2/3, elongated, reedy, endothelial swelling, scale crossed with neutrophils, lymphocytes that have excessive cytoplasm. When you read textbook descriptions, they often discuss a lymphohistiocytic infiltrate. When you do a CD68, there are really very few histiocytes. They are activated lymphocytes with excessive cytoplasm. So there again is the endothelial swelling. Think of it as a vessel without a lumen. This is that so-called lymphohistiocytic, but when you look at it, they're all pretty much black nuclei. You don't have a lot of vesicular nuclei there. They are lymphocytes that just swim in a sea of cytoplasm, which is a very important clue for the diagnosis of syphilis. So ask yourself honestly, would you have even thought of syphilis in this case, where you have a patchy perivascular periadnexal infiltrate? There are some eosinophils. A lot of people, if you're honest, with yourself? The answer would be no. There is some endothelial swelling. There is a busy interstitial pattern. And so those can be helpful clues. Neutrophils in the corneum. Plasma cells can be numerous, but don't count on them. That's the London on a foggy day appearance. There's London on a foggy day, but the buildings would be downward if they're the reedy ridges. So there's London on a foggy day, which is a very common clue to the diagnosis of syphilis. This is also syphilis. One of the things that we did is we looked at cases of syphilis where there were very few diagnostic features. In those cases, you don't get elongation of the reedy, you get just the opposite. You get effacement of the reedy. So you can't count on that, especially when few patterns are present. You're more likely to have effacement, but the most reliable features are absence of lumen and interstitial busy dermis. And what you have in this case, you still have lumen with red cells. You do have a busy dermis with an interface process, a little bit of sponge too, and that should get you thinking of the possibility of syphilis. Again, you've got those lymphocytes with a little bit of excess cytoplasm, busy dermis, a few plasma cells present in this particular case. One with more elongated reedy. This one would be easier. Jim Fitzpatrick was always fond of saying, even the elevator operator knows this one's syphilis, right? They don't need us and our special expertise. Scale crust, elongated reedy, newts in the reedy, all of those things should get you thinking. Remember cases with fewer features, a little bit of interstitial busy, a mix of spongiotic and interface often present, and effacement of the reedy pattern. This again is syphilis, effacement of the reedy, a few newts in the horn, little busy interstitial pattern. And again, syphilis, in this case, plenty of plasma cells. This one people probably would have thought of, but many of them are missed. And elongation, endothelial swelling, excess cytoplasm to the lymphs. I keep emphasizing these things because you are going to see syphilis coming across your scope and you don't want to miss the diagnosis, right? So these are all cases of syphilis. So the incidence continues to rise. There was a spike during COVID. Initially they thought there was less social interaction. It turned out there was more social interaction because of lack of other things to do. I suppose if you weren't going to the movie theater, you had to find some way to spend your time, right? So it is the great imitator. False negative laboratory tests are more common if there is HIV infection, including prozone reactions, because those patients tend to have very high titers of antibody, which give false negative tests. Even with the new syphilis IgG assays, we see false negatives. So wide spectrum detection of spirochetes, 33 to 70%, IHC only about 70%. So you really have to suspect it with clinical pathologic correlation, and anytime you see histologic features that might be suspicious. So we looked at about 100 cases of syphilis for this particular study and found that these were the most common features. But there's a difference between the most common and the most helpful, right? The most helpful are the ones that are consistently present when you don't have a lot of features present, right? So those that occur with as few as only 2 features present to suggest syphilis, right? So no biopsy specimen that we reviewed had only a single feature, but quite a number had only 2 features. And when you looked at that, that's sort of your spread of how many cases had how many features present, right? And most of them are somewhere in the middle. These were the overall frequency of histologic features that we found. But the cases with 5 or fewer, there was effacement of the rete. 4 or fewer, still effacement, interstitial inflammation, endothelial swelling. And as you got to fewer and fewer features, lymphs with ample cytoplasm, endothelial swelling, interstitial inflammation, those were the things that remained as helpful features. So, few features may be present and you don't want to miss it. So be aware that interstitial busy pattern, the endothelial swelling, irregular acanthosis, or effacement. And, the ones that I think are most important are the ones when few features are present. The mix of vacuolar and sponge, especially when there's a lymph in every vacuole, should get you thinking of syphilis as well. And then we looked at other conditions like mycosis fungoides, pityriasis rosea, pityriasis lichenoides. Those are the things that are in the clinical as well as histologic differential diagnosis. Interstitial inflammation was very helpful distinguishing from pityriasis lichenoides, where plasma cells were not helpful. It was not helpful in distinguishing from MF. Papillodermal fibrosis was the best feature to distinguish from mycosis fungoides. And then the elongated rete does favor syphilis over pityriasis lichenoides, which tends to have an effaced pattern. In mycosis fungoides, papillodermal fibrosis, the hardest is pityriasis lichenoides. Those patients, you probably want to get serology in those patients and make sure you look at them very clinically, because Louis maligna, rupioid syphilis, looks very much like pityriasis lichenoides clinically. So these are your take-home points, right? I really kind of hammer away at this because syphilis is on the rise, especially in urban areas in the US, but in rural areas as well. I mean, there's no part of the country where you don't see it. And some of the biggest epidemics have been in rural America and actually in nursing homes in Florida. One of my residents said it's nice to know that there's more to look forward to than Medicare. But nursing homes, people are still having sex and they're not bothering with protection. They're often widowed and they are looking for companionship, and old people get syphilis. So a little more on the data, especially someone sends in something with a diagnosis of MF, PR, pityriasis lichenoides, consider the possibility of syphilis in those cases and look for that interstitial busy dermis, endothelial swelling, lymphs with ample cytoplasm. Okay, next step, of course, is to look at positive and negative predictive features where you've got a lymph in every hole pattern. And how useful are our criteria? We really haven't looked at them. There's a lot of work to be done in DermPath. So 3 points to remember here. Mix of inflammatory patterns, think syphilis. Mix of inflammatory patterns, think syphilis. Drug, viral syphilis, right? Mix of inflammatory patterns, think drug, viral syphilis. Point 3, mix of inflammatory patterns, think drug, viral syphilis. Please don't forget that because it really will save your butt on numerous occasions. And the end of the day, DermPath is an art, right? And it's a complex skill set of pattern recognition, and we can do better by seeing some volume of images, which is why I spent a lot of time on this one. Okay, skills can be learned, right? So the challenge for us is to deconstruct our diagnostic criteria, because when we look at textbooks, they always discuss the most common features. You really need to look at the features that are most helpful when not all common features are present. And, there's a lot of work to be done there. So we can always do a little bit better. Okay, let's move on to the fungi. We love to eat them. Please don't eat the ones down at the bottom, the red ones with the white spots. But fungal infection as immunosuppression with biologics, with other treatments that immunosuppress, targeted immunosuppression for cancer treatment, especially since echinocandins are widely used to prophylax against candidiasis. There are other forms of fungal sepsis that have emerged as one of the most important causes of death among patients with complex medical disease. So we're going to look at some of these cases. We're going to start with a 7-year-old female who was thought to have a soft tissue sarcoma on her scalp because of this large draining mass. But our pediatric pathologist brought it over to me saying, Dirk, this is definitely a you case, not a me case, because there were grains all through the tissue, right? And those grains were positive with Fontana, and they have peripheral chlamydospores, but it grew M. canis. So this was a child whose mother was a drug addict. She was in foster care, sort of acting out, and passed from one foster home to another. She had adopted a stray kitten that she found in an alley, was hiding it in her room and sleeping with it on her pillow. And she had developed a mycetoma on her scalp from M. canis. Takeaway points. All human beings have melanin, just to varying degrees. All fungi have melanin, just to varying degrees. All fungi are Fontana positive. Fontana positivity does not equal black mold. Okay, next case, 50-year-old ice cream man was in a motor vehicle accident. Drunk driver slams into the ice cream truck. He is propelled through the windshield, skids on the pavement on his head, is in the ICU with massive cerebral edema on massive doses of corticosteroid, and we get a referral for a new fungal lesion. This is him with anasarca, and his scalp looks like a petri dish of white fungus. And the ICU nurses, whom I knew well, said, he did not look like this at change of shift. I mean, this just blossomed within the last few hours. That can only be one thing. That is mucormycosis, right? Mucor are the vasculotropic, angiotropic fungi that cause fungal sepsis and necrose tissue that are non-septate. Most of the fungal world is septate, and it grows a little bit, stops, lays down a septum, grows a little bit, stops, lays down a septum. Mucor just grows because it doesn't have to lay down a septum. And for that rapid growth, it needs a lot of carbohydrate. It's fruit fungus, right? It's what grows on those moldy strawberries that you have. Why are you not allowed to bring fruit and flowers into the ICU? Here, I bring you this gift of mucor. It's not a nice thing to do, right? So that's why it's prohibited. So this patient, it was in winter time. There was hypothermia. The patient developed crystallization of all of his fat, sclerema. So to ventilate him, they had to cut him down to his ribs circumferentially all the way around his body. So when the ventilator would blow, you would see this expanse of white ribs appearing. But what's going to kill him are the little hollow red tubes. There they are, irregular, red, hollow. During training, you were probably taught right angle versus 45-degree angle branching. That is total nonsense. It does not work. Red, hollow hyphae that are irregular are mucor, right? Surgical debridement, posaconazole, subuconazole are particularly active against these. Remember, they like carbohydrate, right? So they like sweet things, strawberries, diabetics. This patient is on high doses of corticosteroid for cerebral edema, and the blood sugars are out of control. One of the important things to stop the growth of the fungus is you plunge the patient into hypoglycemia. So you starve the fungus so you can kill it with drugs before it kills the patient, right? There are lots of new antifungals, and they are specific to different types of fungi. And unfortunately, by the time they grow in culture, the patient is dead. So it's up to us to identify them histologically when we get either a calcifluor white of the tissue homogenate on the CP side or the frozen section or permanent section on the AP side. Different drugs for different organisms. Mucor in particular stains poorly with fungal stains. Now, my daughter, who's a dermatopathologist at UAB, sees a lot of rhinocerebral mucor because they have a lot of poorly controlled diabetics in the state of Alabama. She's had pretty good luck with GMS when there are masses in the sinuses. In skin, in tissue, I've had very poor luck with GMS, PAS, DCAS, fungal stains. Excellent luck with tissue gram stain. And we recently completed a study where with Malditoff, we grew fruit fungus, proved what we were growing was Mucor rhizopus, stained it, and rhizopus in particular stains very poorly with fungal stains, but better with tissue gram stain. Important because tissue control of margin, frozen section control of margin, is important to know that complete excision has been accomplished. So this is that same patient after excision and drug therapy and now granulating. So these are horrific but survivable infections. Next patient did not survive. 22-week gestation infant born of a traumatic abruption at the site of a motor vehicle accident, ventilator dependent. Were consulted for what the nurses believe are decubitus ulcers that have occurred on the back and buttocks. That's the baby, little premature baby. You can tell by the IV tubing how small this infant is. And these are what the nurses thought were decubitus ulcers. But you see in the small of the back on a convex, or I'm sorry, concave surface, you see lesions. So decubitus ulcers, of course, don't happen on a concave surface. So what you're seeing, it's been called the halo sign, this depressed black leathery eschar with a scallop border and a halo of red around it is highly indicative of fungal sepsis. And this looks different from the last one. So remember the last one, mucor, was red-walled and hollow. This has a blue wall and has visible cytoplasm. So you see a blue wall, visible cytoplasm, and chlamydospores, which are those soap bubble-like swellings of the fungus. You put those things together, that's a black mold. And the patient needs high-dose itraconazole as a life-saving measure, right? So mucor, red, hollow, black mold, thick-walled, refractile, blue wall, visible cytoplasm, soap bubble-like chlamydospores in tissue. So, that equals phaeohyphomycosis. search for pigment just makes them easier to see if you do a Fontana. But if you actually see brown pigment and chlamydospores, that helps you that it's a black mold. Often, though, you're not going to see that brown pigment in tissue. What you're going to see is a thick-walled blue organism with visible cytoplasm and soap bubble-like chlamydospores. That is a black mold equals high-dose itraconazole for therapy, right? So these are the black molds. Bipolaris spicifera is the most common cause of fungal sepsis with black mold. You saw it this morning when you took a shower. You inhaled it this morning when you took a shower because it is common mildew. And if you really want to be scared, unscrew your shower head and look inside. It is not pretty, right? There is fusarium and black mold in your shower head and you inhale it. The reason you're not septic is you have neutrophils. If you are immunosuppressed, you can bathe, but you should not shower because of the risk of fungal sepsis. Okay, let's look at some other fungi. So here we have a combination pseudoepitheliomatous hyperplasia, PEH with pus. That you think of various things, halogenederma, is a common one. So, we have a mnemonics for various things. So here come big green leafy veggies, covers everything from pemphigus vegetans to the infectious organisms and halogenederma that can cause PEH with pus. In this case, you see a thick-walled asymmetrical organism. So you see how asymmetrical that wall is, how the nucleus is towards one side and how refractile that wall is. That is blastomycosis when you see it. Paracoxy, which is much more a South American organism, but we do see lots of people in the US from South and Central America who are working in restaurants, picking crops, doing all sorts of productive work, and they get sick and they come in to see us. So they may have brought an endemic organism with them. So paracoxy has a much thinner non-refractile wall and often a mariner's wheel pattern of little spores at the periphery of a central spore. Calcofluor white is very helpful for tissue homogenate. You get an instant read on whether you've got a septate or non-septate organism, thick wall, thin wall. So this is your mnemonic for PEH with pus. Here come big green leafy veggies, halogenederma, chromoblasto, granulum ingranale, leash, and pemphigus vegetans. Helpful to have those because some are infectious, some are not, and you don't want to miss any of the possibilities. So chromomycosis tends to be more indolent in the skin, and you see these characteristic copper pennies within giant cells. Tends to have a male predominance, especially people who are working outdoors, working in agriculture, working in landscaping. And then verrucous plaques, it's a type 2 immune response, whereas atrophic lesions have a type 1 response. Those with a type 2 response are more likely to go on to widespread infection. And a lot of them fail therapy. So hyperthermia together with antifungal therapy can be helpful. A combination of itraconazole with terbinafine shows very good fungal sensitivities in vitro and has been proven to work in vivo as well. Okay, this is a patient who was in the US military, went to the high desert of California for basic training, then developed pneumonia and these verrucous skin lesions. And of course, that would be coccidioidomycosis, right? So cocci, you're going to see these lacy large spores in tissue. Do not grow it except under a hood because those barrel-shaped conidia break off, aerosolize, and are highly infectious in the lab. Mainly southwestern United States, but it is spreading. As climate changes and you get drier, hotter areas of the US, its range is definitely spreading, and you will see it in other parts of the country. Severe disease, especially in immunosuppressed, the elderly, infants, and people with B or AB blood type. And then amphotericin plus minus, fluconazole is how most people are treated these days. And then itraconazole, not effective for meningeal disease. So that's important to remember. There are some newer agents that have been used. Voriconazole, very toxic, of the imidazole drugs, not something you would normally reach for, but can be life-saving in these cases. And then that's the endosporulation that you'll always read about. If you wait for that, you're going to miss the diagnosis. You got to recognize these large spores with the lacy cytoplasm. Crypto, we mentioned the molluscoid lesions, umbilicated lesions in patients with HIV, but it can also present with an indolent cellulitis. You get pleomorphic yeast that vary in size and shape, have a thin wall, and are typically in a gelatinous capsule. In processing, the gelatinous capsule shrinks. So with mucicarmine, you see a tiny little pink halo around the organisms. And then Fontana is how we normally stain, taking advantage of the fact that all fungi have pigment. And when you grow it in culture, sometimes it will grow as a brownish color, um, which correlates with the strong Fontana positivity. Patients with HIV are particularly at risk for disseminated disease and death, so you don't want to miss those molluscoid lesions. But these patients with the cellulitis can also go septic with it. For those seriously ill, it's going to be amphotericin followed by a fluconazole. And less seriously ill, you just start with fluconazole for those patients. 600 milligrams of itraconazole has been shown to be effective in some studies for patients. Sporotrichosis, you get this lymphangitic spread that is typical. We tend to see that with nocardia as well as with sporotrichosis. Histologically, you're going to see palisaded granulomas with a neutrophilic abscess in the center. Looks a lot like GPA, like granulomatosis with polyarthritis or polyangiitis, right? GPA, what used to be called Wegener's granulomatosis, has the same histology as sporotrichosis, as do atypical mycobacteria. So you got a spectrum, and if you're lucky, you're going to find these cigar-shaped yeast, but they are very few in number. So you really have to suspect the possibility based on the clinical and the palisading granuloma. Fixed cutaneous sporo doesn't have the lymphogytic spread, but is also quite common. And then again, you can grow it. These are more indolent infections. You do have time to grow it. It actually grows pretty easily in culture if you suspect it. Disseminated disease in cats, and there are cases that are commonly transmitted to humans through a cat scratch. Something that we see in the lab, usually a big excision specimen for melanoma, and it's actually tinea nigra, especially in the humid southeastern United States. I'm fond of saying it's so humid here, even the people mildew. And so you see tinea nigra. So often comes into the lab as a suspected melanocytic lesion. You're really not seeing anything. Look up in the corneum. Rhinosporidium tends to be anywhere where people have to bathe in water that's not chlorinated. And that's much of the world, right? And you'll get these polypoid lesions that can be genital, nasal, conjunctival, and the organism is huge. It's a big endosporulating organism that is tough to miss when it looks like that, but you have to recognize the non-endosporulating form, which kind of looks like a Halloween eyeball. So a big white sclera, some granular red, and then that central nucleus with the eccentric nucleolus looking like an eyeball looking downward. Schistosomiasis, we definitely see, and it often presents as an anogenital lesion. Here you can see that thin wall, the characteristic stippling in the middle, and the little spine at the end of the oval telling you it's hematobium, which is usually what we see in skin. That's what disseminates to skin. Just in contrast, those are often mistaken for one another, but the spine at the end, the oval configuration of the schistosomes help distinguish them. Phaeomycotic cyst is a more indolent infection with black molds, usually from implantation of a splinter. If you see splinter in tissue, you're usually going to find some brown organisms in it that can grow either a spore form, chromomycosis, or in hyphal form, phaeomycotic cyst. This is the baby with sepsis, very similar group of organisms. Again, remember, it's going to be blue wall, chlamydospores, visible cytoplasm. Rhizopus, we looked at, red wall. That is 45-degree angle branching, folks. Tells you what you learned was not true, right? These can branch at 45, but they are red, hollow, irregular, so you're not going to miss it, right? This is a baby who died with aspergillus sepsis. Aspergillus, you don't see a wall at all. The wall is so delicate, all you see is blue cytoplasm. That's when you think of aspergillus, and you can see the vascular invasion. And then fusariosis looks just like aspergillus, except it forms chlamydospores, which aspergillus is not capable of doing. So you see a thin-walled blue organism. Black molds are thick refractile wall. A thin-walled blue organism with visible cytoplasm and chlamydospores is fusarium. Helps you start voriconazole early. Again, toxic drug, not what the ID folks are going to reach for unless you tell them it's fusarium. And then this is a DCAS stain showing those nice chlamydospores. Histoplasmosis in culture and a cannulate macroconidium, but again, the patient may die before it grows in culture. This is what we were all taught. Very evenly spaced polka dots with a little white halo around them. But this is also histoplasmosis. This is the African form, where they're much, much larger organisms and tend to be randomly clustered within large giant cells. And that is also histoplasmosis. So you all learned about dimorphic fungi. And we were told in culture it is hyphal, and in the body it's a yeast. Again, that is a total myth. It's oxygen tension. In the lung, histoplasmosis becomes hyphal. In blood vessels, histoplasmosis becomes hyphal when it hits oxygen. So it's not the temperature, it's the oxygen that makes it grow in hyphal form. So you'd look at this and you'd probably think aspergillus, right? Remember that Penicillium marneffii and histoplasmosis are the two organisms most likely. Penicillium marneffii, they now call Talaromyces. You can use either name. They can grow hyphal and they look a lot like aspergillus. So you got to remember that that's an important differential diagnosis. And then lobomycosis is increasing in incidence because more and more we build along the coast. And as the water becomes more brackish with a lot of sewage effluent going into the bays and lots of people living there, people are going to start to get lobomycosis. Keloidal lesions with these pop bead-like organisms in a row connected by tiny little snouts. And in case you had a deprived childhood and didn't have pop beads, this is what they look like, and that's what the organism looks like in tissue, right? So remember, new antifungals, different fungus, different drug. So it's really up to us to identify these things in tissue so that the patient gets appropriate treatment. This is a transplant patient with cutaneous nodules, widespread all over the body. pH with pus. So we were thinking, here come big green leafy veggies, right? That was our differential. But the organism's funny. It doesn't have an eccentric refractile wall. It's very pleomorphic. It's sort of all over the place in morphology, very hard to place. When you see that, think of dermatophyte sepsis, especially in immunosuppressed patients. There are even little hyphal bits as well as budding yeast in this patient. There you see the hyphae, and it grew T. rubrum, athlete's foot fungus. So when you get fungi that really sort of defy morphologic diagnosis in tissue and your patient is immunosuppressed, think of dermatophytes. When you get papillodermal edema like this, we think of polymorphous light eruption, Sweet syndrome, perniosis. But look up at your corneum. You see that layered horn where you've got basket weave sitting on top of compact red. Anytime you've got basket weave sitting on top of compact red corneum, think of dermatophytosis, think of tinea. And you look in there, you're going to find your organism right at the junction of that compact red and the basket weave. Something that is spreading and is now very common on American beaches is tungiasis. It's a flea that burrows into your toes when you're walking on the beach barefoot, and nothing else looks like it in tissue. So you're on acral skin, and you see this blood-filled organism with lots of ova inside, and it's a female engorged flea. That's kind of what it looks like, and nothing else looks like it. And that's it clinically after someone has taken a nice walk on the beach. Few other things that you don't want to miss. So here you have these spheroid structures with necrosis of a vessel. That is a canthamoeba, and it's usually an immunosuppressed patient, and they're going to die if you don't identify it as amoebiasis. And they look a lot like histiocytes or CD30 positive atypical cells. They can even pick up some CD30 staining if you can lead yourself down a very wrong path with these if you don't recognize that refractile wall as being an amoeba. So that's it for the talk. We're going to end with a scanning micrograph of a flea. And you can see that between every scale of the flea's body, the flea is heavily infested with mites. And that is the usual state of affairs, that fleas are infested with mites. And although there's no way to prove it, it's my personal hope that the mites make the fleas itch like hell. And with that, I thank you very much. And if you have any questions on these, our emails are super easy at MUSC. I'm just elston@musc.edu, and welcome your questions, and always happy to help with interesting cases, especially those of infections.
That was amazing, Dr. Elston. Thank you so much. Thanks a lot.
My pleasure. Thanks for inviting me.
Thank you, Dr. Elston. Can you turn on your video if you can?
I can for just a second here. Let's go.
Dr. Skopsky, would you like to add anything and
turn on.
Have any questions for Dr. Elston?
So no questions. I just want to again reiterate a huge thanks, Dr. Elston. He's truly a rock star in the field of dermatology and dermatopathology. So his generosity, sharing his time, his brilliance with our community is so much appreciated. I also just wanted to reiterate about his textbook, so Dermatopathology. I use the first edition. I would say it's the foundation pillar of my derm path education on which I've built all of my knowledge. I've leaned on it from the beginning. I still do today. So I would say it's an absolute must read for any dermatology or pathology resident. And the newest edition, the fourth edition, is exceptional new updated annotated images, and there's videos that really bring the content to life. So highly encourage you to get and read that textbook. And Dr. Elston, thank you so much again for your time, teaching, and impact in our field.
Well, thank you. Thank you for hosting this series, and I hope people found it helpful.
Absolutely, Dr. Elston, and it was very helpful. I'm sure a lot of our colleagues have joined from all over the world, and you would be happy to know that I could keep a track of our colleagues. They joined from far away places like Nigeria, Tunisia, Kazakhstan, Somalia, Mexico, Tajikistan, Peru, Thailand, India, to name a few. And
Well,
it's
that
it's a
warms my heart.
really
We have an international dermatopathology fellowship in addition to our US fellows. Right now, we have fellows from Oman, Kuwait, Bahrain, China, and we welcome people from around the world to spend some time with us.
right. That would be great. And then, as you have mentioned, that they can, those who are listening now, that you can reach out to Dr. Elston if you are interested to get trained under him. And as he said, his email is easy to remember. Dr. Elston, if you can say it again, I can put it in the
Yep,
text box.
it's just my last name, Elston at MUSC, which stands for Medical University of South Carolina. Elston at musc.edu.
Right. So you can email him, elston@musc.edu. I am putting it on the chat box as well. There are a few questions, Dr. Elston, if you have a few minutes,
Sure.
I can read it for you. So one question is about how often do you find that syphilis mimics other dermatosis histologically, and what are your go-to stains or clues to confirm the diagnosis?
Okay, so how often does it mimic? Always. Always, right? So we have at our multi-headed scope, we have spirochetes that someone gave me that are curled around all the tubes of the multi-headed scope so that we're always looking at them and always thinking of syphilis in the differential. Especially PR, pityriasis lichenoides, MF. Syphilis likes to mimic all of those things. So the things that are helpful, combination of inflammatory types, especially sponge plus interface, think of drug viral syphilis, busy interstitial dermis, no lumen to the vessels, and then the last one is excess cytoplasm to the lymphs. So the lymphs, normally you just see a black round nucleus. When you see some cytoplasm there around the lymphs, think of syphilis.
Thank you. Staying with syphilis, there are a couple of more questions. One question that is there is that what is your approach to ordering special stains or molecular tests in suspected cases like IAC for Trypanosoma pallidum or PCR for
Yeah.
that matter?
So, we love our T-Pal stain. We use a red immunostain for it because melanin's brown. With silver stains, melanin is black and granular, whereas spirochetes are gray and not granular, and they tend to cluster right where the melanin does, down along the basal layer. So you got to distinguish the two. So we start with IHC, but we still do Steiner stain when we have a high index of suspicion. We look at the clinical, we look at serology, because almost any test in syphilis is only 70% accurate. So, and you don't want to miss the diagnosis. So you have to use multiple modalities when you suspect it. And the big thing is just suspecting it, just thinking of it on H&E and talking to the clinician.
Right. I think you must have already mentioned it, but still I will read this another question for you. So that are there any particular histologic features that help you in distinguishing secondary syphilis from other spongiatic or lichenoid dermatosis?
Yeah, the combination of spongiosis plus interface, the busy interstitial dermis, the endothelial swelling, the excess cytoplasm to the lymphs. Those are more reliable than plasma cells.
Right. And regarding epidemiology, there was one question, Dr. Elston, that do you think the rise in syphilis is being adequately reflected in clinical practice, or are we under-recognizing it?
Oh, we are definitely under recognizing it, no question about it.
Right. Uh, I think there are a few questions about fungal infections. So one
Sure.
question is, let me share with you that what's the role of immunostain for identifying fungi, or should we use only morphology?
Yeah, so a few things have been tried. PCR has been tried, and Mayo actually discontinued offering their PCR because of false results. So PCR proved to be unreliable and could result in patient death. And so they discontinued offering those tests. The same for IHC. So there is IHC that works very well for fungi, but it stains all mycobacteria and all fungi. So it doesn't distinguish between them. And, because of that, we're really kind of back to morphology. And morphology is pretty reliable, and it's not that hard once you learn the rules.
Right. I think you touched a very important point about morphology, because there was a second question that how do you approach cases where fungal elements are sparse on morphology or the morphology is ambiguous on H&E? This question was from another viewer.
Okay, so get deeper sections, keep looking. The other thing is you can use fungal stains, and when they don't stain well with fungal stains, and they're few in number, go to your fluorescent microscope,
Hmm.
because almost all fungi fluoresce. And there are some clues, like if your entire corneum fluoresces, that's candidiasis. Psoriasis also has your entire corneum fluoresce. So, those are things that can be helpful there. The fungi themselves fluoresce, so it can be a little easier sometimes against a dark background to make out the morphologic features, the thickness of the wall, presence or absence of septi, chlamydospores, the various things that help you distinguish between them. And remember, if you have fungus that defies diagnosis, it just doesn't want to follow any rules, think of disseminated dermatophyte infection. And remember, aspergillus, hyphal histoplasma, Talaromyces marneffii, those are big lookalikes in immunosuppressed patients. So, you got to know where your pitfalls are as well with morphology.
Right. Right. So about stains, there is a question, Dr. Elston, that do you have a preferred stain, like whether PAS or GMS, for detecting organisms on skin biopsies? And if you have
Yeah.
a preference, can you please explain why?
Yeah. So, MUSC is a very old institution. McManus, who developed the PAS stain, was at MUSC. I think we are the only university in the world that doesn't use his stain. We use DCAS, um, dichromic acid Schiff. So DCAS or PAS, the McManus method, the reason that people don't like it is the fungus is red and the background is red. But you can use a green counter stain for a PAS to make it look like a DCAS stain, and it's much easier. So if you look at any of your staining manuals, like the AFIP manual, you can find methods for PAS with a green counter stain. It's just called light green when you order the stain. Um, eh, or DCAS, those are far easier to interpret than GMS, Grocott stains are. And then remember for mucor, when you suspect it, Gram stain may be much better at showing organisms at the periphery of the excision specimen and whether your margins are still positive. Gram may be much more sensitive than any fungal stain.
Yeah, that was a question that I was interested to ask you because you mentioned gram stain in your talk too. Like, I mean, is it quite useful in detecting organisms on tissue sections, gram stain?
So, certainly for bacterial organisms,
Yeah.
for mycobacteria, if you go back to the last lecture, auramine, rhodamine,
Mm.
right? 50% of organisms that you can detect with auramine, rhodamine, you see nothing with a phyte or Kenyan stain. So phyte or Kenyan stain picks up only half of cases that are AR positive. So auramine, rhodamine is definitely your stain if you're looking for acid-fast bacteria. Gram for conventional bacteria and also for mucor in tissue. And I prefer the brown hops to the brown Bren. Just it's a little easier to see the organisms because your background is a light yellow and the organisms stand out a little better, especially gram-negative organisms are easier. Gram-positive you can see with pretty much either method, but brown hops is definitely superior for gram-negative organisms.
Right. Thank you. And so another colleague of ours wanted to know that what is your approach about tissue culture or molecular testing for suspected fungal infections? Do you recommend it or what about that?
Yeah, so I mean, we always do the tissue culture, um, but we have to institute therapy long before anything grows in culture, right? So that's based on morphology. Um, Remember that for fungal culture, do not let them use glass beads and grind up the tissue in the lab, or they will render the fungi non-viable and they won't grow. So, usually in the microsection, when they do a tissue homogenate, they use glass beads and they grind it up. You can't do that if you're looking for fungi. And you can't do that if you're looking for amoebas. And for amoebas, you need to grow it on a lawn of E. coli. So you plate agar with E. coli, so you have a nice dull growth of E. coli all across it. And then the next morning, after you place the tissue there, you have all of these shiny snail trails where it's eaten the organisms. That tells you got amoeba. So it's pretty easy, and you get your answer within 24 hours. In terms of the molecular studies for fungi, they have really been disappointing in terms of specificity. So they're sensitive, but they are not specific. And so you can make real mistakes that result in bad outcomes. So, um, light microscopy and a good eye are still what's going to save the patient's life.
All right. Well, thank you, Dr. Elston. So another question I saw on Facebook, though not related to today's lecture, that how do you diagnose cutaneous tuberculosis when you see granulomas without necrosis?
Yeah.
I think you
So,
covered that still.
I'll take it even further back. What is sarcoidosis? There is, there are certainly those patients have a tendency to form granulomas, but there are increasing numbers of sarcoidosis patients who are found to have either leprosy or mycobacterial infection that was undiagnosed. It- so, always think of the possibility that it's not sarcoidosis. The problem with lupus vulgaris or common tuberculosis, verrucoid tuberculosis in skin, organisms are extremely difficult to find, especially if you're relying on old-fashioned acid-fast stains. And auramine rhodamine is definitely your choice for that. So whether it's leprosy, tuberculosis, or non-tuberculous mycobacteria, AR, or amine rhodamine is your stain.
Thank you so much. Dr. Skupski, sorry, would you like to say anything, add something for Dr. Elston or from your side?
No, just again, a huge thank you. This is, immensely, immensely helpful lecture for all of us. Thank you.
Okay, my pleasure. Thanks for inviting me.
Thank you so much. Thank you so much again, Dr. Elston, for this excellent lecture. And I already shared the link to Dr. Elston's book, which is the Dermatopathology, already in its 4th edition, which is a must read, as Dr. Skopsky also mentioned. So this is the screenshot of the same. So please consider buying it. You can get it on Amazon as well. And as Dr. Elston mentioned, that even the 4th and 5th edition is coming up soon. So stay on alert for that as well.
Well, the 4th edition just came out. We've started
Right.
work on 5th, but that's not going to be out for another 4 years. So it's the 4th edition that just came out. The image right at the top there, when you see that parallel theca pattern with compressed red collagen in between, you are looking at melanoma.
Right. Right. Thank you. Thank you. Sorry about the wrong information. So this is the 4th
No,
edition
that's
of the book.
fine. Yeah, the 4th edition's brand new, just came out.
Right. So all the our colleagues, so please consider reading it. And as Dr. Skopsky mentioned, that this is a must read for all dermatopathology enthusiasts. And we are very lucky to have Dr. Elston giving us talks for all of you. And thanks always for following Padcast. So you can follow us on our social media platform so that you can stay updated with all the lectures, and all the lectures are archived and you don't have to register. They are all for free. And we always encourage your participation. And we will continue with our lecture series, and our next lecture is on July 22nd, and we will move to GI pathology this time. And our speaker is Dr. Deepti Dhal, so who is going to talk on a very relevant topic on day-to-day problems in colon cancer diagnosis. So hopefully you will find it useful, and please join us on that day, that is 22nd of July, same time, that is 9 a.m. Pacific and 12 p.m. Eastern time. And thank you again, Dr. Elston, for your excellent talk, and thanks to Dr. Skopsky as well. Thank you so much.
Okay, thanks so much. Bye-bye.
Thank you.